Distinguished faculty member, colleagues, and esteemed postgraduates, students in surgery, Assalamu alaikum, and very good evening and welcome. So, at our time, general surgeon used to do a pancreatic cancer surgery. Now it is fully the domain of the hepatobiliary and the pancreatic cancers. But as a general surgeons, one should know the in-depth understanding of the principles of the investigation of the pancreatic problem and cancer, and at the same time, the principles involvement in the management of the pancreatic cancer, as well as the referral of the patient to the appropriate center at appropriate time. So today in this session, we have a very distinguished general surgeons, GI, hepatobiliary, and pancreatic oncosurgeons, and the liver transplant surgeons. And we also have a medical oncologist and a pathologist. I hope you will enjoy the session and we'll have a very wonderful time with us. Dear students, it is your platform. Please participate actively and enroll your name for the upcoming presentation via this email and the WhatsApp number. Few words, no harm to say I don't know. Jamuna. Today, we'll learn many things from our foreign guest and from our local experts and talents and the faculties. So we will learn many things today from them. Just keep an open mind. All the faculty members here are very friendly. Here we are here to give you a clear understanding about the subjects on the pancreatic cancer. Engaging in the discussions and presenting cases effectively not only strengthen your knowledge, but also enhance your ability to think critically and communicate with your examiner during exams. Please ask as many questions as possible and seek clarification when necessary. Participate actively, demonstrate your enthusiasm and an active involvement in the discussions. Please participate actively. I have nothing to disclose, but the information usually provided here will be taken from the journals, guidelines, seminars, and the online CME. Our today's topic is the pancreatic cancer, and our discussion chronology. First, there will be polling, followed by a case presentation, and then a faculty presentation by our esteemed guest, Dr. Shivendra Singh, to then a question answer session and comment from the faculty member, and the brief summary and the take-home message of the day. Please put your question in the chat box. Your each and every questions will be answered. So with these few words, we will start with the polling. Polling will be moderated. Dr. Mohammad Saiful.
So our first question today was true statement regarding pancreatic cancer. Near the options were nearly 85% of, please mute. Nearly 85% of patients present with unresectable or metastatic disease. Option 2, more than 85% cancer at ductal or head, that is from head glands, ductal adenocarcinoma. Introduct IPMN arising from main duct can be diagnosed on ERCP. It is visible secretion of the thick mucus from the ampulla during ERCP. May associate with Lynch, Peutz-Jeghers, or FAP. So these are the common genetic problem we encounter in our general surgical practice. So it could be associated with carcinoma head of pancreas. So all of the above. So here the true statement is all of the above. About 89% student correctly answered. So our next question is high risk features for pancreatic cancer includes equivocal or indeterminate imaging finding, markedly elevated CA19-9, large primary tumor, large lymph node, extreme pain or excessive weight loss, all of the above. So here the correct answer is all of the above. About 79% student correctly answered. So next question. Find out the false statement regarding CA19-9. So the options were may be elevated in cholangitis or obstruction, may be normal in or low in Lewis antigen negative individual in 5 to 10% of cases. So we know that CA19-9 is also called sialyl Lewis antigen. It is almost 80% cases it is sensitive in case of malignancy or obstructive jaundice. Only 5 to 10% cases it is negative. That is we call them non-secretory. Then more than 1,000 always indicates malignancy. That is a false statement. So here the correct answer is more than 1,000 always indicates malignancy. In case of obstructive jaundice due to other cause in strictures, the CA99 may be raised, but it does not always indicate malignancy. CEA and CA125 should be done in patients who are non-secreting. That is a true statement. So our next question is principle of management of jaundice in carcinoma head of pancreas includes all except. So we know there are few general things. Management of obstructive jaundice, we know it very well since our MBBS level. So we put the options regarding the carcinoma head of pancreas only. So our options were biliary drainage is mandatory prior planned surgery. EUS needle biopsy and ERCP for biliary drainage is the best practice in same setting if required, if it is available. Biliary drainage is considered in cholangitis, intense pruritus, that is symptomatic obstructive jaundice, palliative, any palliation, or before starting neoadjuvant chemotherapy. Fully covered SEMs are preferable than plastic stent because the duration of plastic stent is very much less, and we use it or recommend it in case of life expectancy less than 3 months or any bridging any therapies, etc. In that case, in case of failed ERCP, percutaneous biliary drainage should be considered. This is also a true statement. So here the correct answer will be biliary drainage is mandatory prior planned surgery. This is a false statement. So we don't need a routine biliary drainage prior planned surgery. If the patient does not have any features of cholangitis, or then we don't recommend biliary drainage prior planned surgery always. The other statements are true here. So our next question is locally advanced carcinoma head of pancreas includes all except tumor in contact more than 180 with superior mesenteric artery or celiac artery, unreconstructible superior mesenteric vein or portal vein due to tumor involvement or occlusion or by blend thrombus, solid tumor in contact with inferior vena cava. Tissue diagnosis is the next appropriate step. So here all are true statement except the solid tumor in contact with inferior vena cava. This is a false statement. Solid tumor in contact with inferior vena cava is categorized as borderline resectable, not locally advanced or unresectable tumor. So all other options were true. So our next question is diagnostic staging laparoscopy may be considered to rule out peritoneal metastasis. This is a true statement. 94% student is correctly answered. What is the recommendation for unresectable disease at surgery? So here a few things often due to our poor interpretation of images, that is CT or MRI. So we often do the palliative bypass. So we most of the sorry to say, but most of the center in our country or surgery done by any general surgeon. So what we do, we embark or subject the patient upon surgery, and during surgery we say that we'll resect or we'll do bypass. So it is not recommended at all. So routine triple bypass, I repeat, routine triple bypass is not indicated at all, not recommended at all. So only if the disease is borderline resectable or we found it during surgery, then the palliative bypass or other things are indicated. So the options are gastrojejunostomy if indicated, if the patient is symptomatic or if there is any gastric outlet obstruction, biliary bypass or SEMS if indicated, obtain tissue diagnosis, celiac plexus neurolysis if pain, all of the above. So here the correct answer is all of the above. So I'm afraid no one answered the obtain tissue diagnosis. So if you don't take any tissue during surgery, if the patient is previously not diagnosed, how will you treat further the patient? How will you give chemotherapy or any palliative therapy to that patient? So here all of the above is the correct answer because all is indicated. Gastrojejunostomy, biliary bypass or SEMS, tissue diagnosis, celiac plexus neurolysis, all indicated if the patient is symptomatic. If the patient does not have any gastric outlet obstruction or obstructive jaundice, then we don't do the bypass. So someone may say that the patient will develop it later on. So later on, we can do the stenting or SEMS or anything. So we don't do routinely the bypass procedure. Please note down this. So our next question is, during pancreaticorenectomy, frozen section should be considered for interaortocable lymph node, bile duct, and pancreatic duct margin. That is, at least 5 mm clear margin is required. So this is a true statement. About 77% students were correctly answered. True statement regarding postoperative pancreatic fistula, that is POPF. 13 to 41% of all Whipple's procedure drain fluid amylase level more than 3 times than serum after third postoperative day. Octreotide can be used to suppress secretion. Soft texture gland, duct less than 3 mm, intraoperative blood loss more than 1 liter are the consistent risk factors. So there are other risk factors, but these are the most consistent risk factors, all of the above. So here the correct statement is all of the above. About 84% student correctly answered. So our next question was palliative options for pancreatic cancer. The options: 1, relieve jaundice and treat biliary sepsis. That is any drainage of bile, that is by any means, that is ERCP or PTBD or PBD. Improve gastric emptying, pain relief, quality of life improvement, palliative CTRT. Okay, so one option is missed here. Actually, all of the above will be the correct answer. It is not given here by mistake. So quality of life improvement means treat the diabetes and the steatorrhea. So this is how we can improve the quality of life. So here all the options are correct. So our next question, number 11, indications for radiation therapy in pancreatic cancer includes resectable or borderline resectable, resected, that is in adjuvant setting, locally advanced disease, palliative setting, recurrent disease, all of the above. All of the above is the correct answer. So NCCN now recommends if routine radiation therapy, even if it is R0 resection. So all of the above is the correct answer. So our last question is preferred chemotherapy regime for pancreatic cancer, that is in neoadjuvant or adjuvant setting, is FOLFIRINOX. This is a true statement. About 89% student gave the correct answer. So thank you, sir.
Thank you, Dr. Saiful Islam, for moderating the poll. Very nicely question you have designed, covering the almost the whole spectrum of the pancreatic cancer. It's very good, and student performance is also very good, I think. Professor Margobhushan, sir, sir, will you make any comment about these questions? Sir, can you hear me now?
Yes.
Yes, sir.
Yes, questions has covered almost every part of the pancreatic cancer, full spectrum of it, but I think the question should be that all of the above, they can be changed into SBA type.
SBA type.
So that they can think of something more. Some thinking process is there. Otherwise, this is almost okay.
Right, sir.
You change it. And my second advice will be that just enlarge the words. The font size should be a bit bigger, that we can read it clearly. ছোট হয়ে যায় আমাদের জন্য।
Okay.
ফন্ট সাইজটা একটু বড় করে দিলে ভালো হয়।
It is possible to give a font size increase?
না স্যার, এটা তো ডিফল্ট অপশন।
We'll try from the next session. Okay, then thank you, sir.
এখন তো না, পরের বারে করতে গেলে তো করতে হবে।
Okay, sir. Okay, sir.
Thank you, sir. Yeah. Dr. Hashim Rabi, will you make any comment about the questions? I think Dr. Shivendra will cover everything in his presentation. So will you make any comment? Want to make any comment? You are muted. You are muted, Hashim Rabbi.
Yes, sir. No, sir, কোনো comment করতে চাই না. The nicely arranged. All the
Okay.
questions have covered the important aspect of the pancreatic cancer. I think Shivendra sir will be highlighting. So we are tempted to attend his lecture rather than making comments.
Yeah. Professor Mohsen, will you make any comment?
Excellent questions. It included all the presentation of pancreatic cancer, including the management also. So nothing to be commented further.
Right. Thank you. Lastly, Dr. Shivendra, please.
Yeah, Saiful has covered all the areas. I think his questionnaire was very good, and it was very well put. And the students also done well.
Yes, sir.
They are still.
Okay, then. Thank you very much. So now we are going to our second segment, the case presentation. Now I will request Dr. Rakib, you please come to the screen and introduce yourself and please present your case, like a case presentations.
Assalamu alaikum, sir.
Walaikum Assalam, Rakib. Yes. Introduce yourself.
Assalamu alaikum. I am Dr. Rakib, General Surgery Resident, Chittagong Medical College. Today I am going to present my case. This is my case. Our patient, Mrs. X, 50 years old lady, non-hypertensive, non-diabetic, presented with the complaints of yellow discoloration of skin and eyes for 4 months, itching all over the body for the same duration, loss of appetite and weight loss for last 3 months. Her presenting complaint started about 4 months back. Then she developed painless progressive jaundice, which was not associated with fever, chills, and rigor. She also complains of itching all over the body for the same duration. She gave no history of anorexia and significant. She gave a history of anorexia and a significant weight loss for the last 3 months. She complains of passing pale colored stool and high colored urine, and she has no history of cough, hemoptysis, hematomesis, chest pain, bone pain, and blood transfusion. She has no significant past history and family history. She is a non-smoker and non-betel nut chewer. She is immunized against according to the EPI schedule and vaccinated against COVID-19 vaccine. She has no history of allergy to any type of drugs and foods. On examination of the patient is ectoric, non-anemic. There is sketch mark all over the body. All accessible peripheral lymph nodes, including left supraclavicular lymph node, are not palpable. There is a cannula in situ in her left breast. All the vital signs are within normal limits. Her BMI was 18 and ECOG performance status was 1. On abdominal examination of the patient, the abdomen was scaphoid in shape, scratch mark all over the abdomen. There is lump in the right hypochondriac region, globular in shape, surface is smooth, firm in consistency, move with respiration, and upper limit cannot be reached, which is consistent with gallbladder. Liver is not palpable. There is and has no other organomegaly present. No ascites. Digital rectal examination, and other systemic examination reveals no abnormality. So my clinical diagnosis is obstructive jaundice may be due to carcinoma head of the pancreas.
Thank you, Dr. Rakib, for presenting your case. Now you will face the faculties. You have to satisfy them. First, I request Professor Margushan sir, will you make any comment about his history, presentations, and salient feature presentations, and the physical examinations findings, and the rationality of the diagnosis? Professor Margushan sir.
The history is typical of an obstructive jaundice due to pancreatitis. History and the clinical findings are just typical. But it is just, I think, for 4 months, there is no history of fever or anything like that, cholangitis. That is something I have noticed, that there is nothing like that, there is no episode of fever or chills and rigors. Accepting that, the patient has lost weight. This can be ascertained from the looking at the abdomen, the folds are there, and he has lost his weight. That is fine. And the usual diagnosis is obstructive jaundice due to pancreatic tumor that we used to get during our early days.
Yes.
The late case, no doubt.
Okay, sir. Thank you, sir. Professor Mohsin, will you make any comment about his history presentations and the rationality of his diagnosis? You are muted, Mohsin. Yes, yes.
This is a very typical features of obstructive jaundice due to distal CVD obstruction due to pancreatic head malignancy. Typical presentation. The presentation is very nice, and he covered everything in his presentation, both also in examination also. So I think it is nice presentation and typical presentation of obstructive jaundice due to pancreatic head tumor or malignancy. Thank you.
Okay, thank you, Professor Mohsin. Dr. Shivendra, will you comment or any advice to the students about?
I just want to make a comment that how he has made a diagnosis of CA head pancreas, why it is not an ampullary carcinoma or a lower end cholangiocarcinoma, how he can rule out all this, but why it's CA head pancreas only.
Okay.
So I don't agree with this CA head pancreas because usually, Rakib, you have any answer?
Yes, sir. It could be a case of it is in my differential diagnosis that it could be a periampullary carcinoma, but in case of periampullary carcinoma, the jaundice is usually fluctuating in type. In case of this patient, this is and it is a case of painless progressive jaundice. In case of it could be a case of cholangiocarcinoma also. But it is a little bit uncommon in our country. So in case of it could be in a clinical diagnosis, I should say it could be a case of carcinoma head of the pancreas.
The only issue is that usually CA head pancreas are associated more commonly with pain.
Yes.
If it is a progressive jaundice and associated with pain, then most likely a head pancreas rather than an ampullary pancreas or a cholangiocarcinoma. If it is painless progressive, more likely it goes in favor of periampullary. That is the usual.
Thank you, Dr. Shivendra, for your nice comment. Okay, then next we'll go to the second segment about these investigations and the management of this patient. So, Dr. Rakib, how will approach this patient?
First of all, I want to do some basic investigation: complete blood count, serum creatinine, serum electrolyte, and chest X-ray and ECG of this patient.
Okay. So this is your basic for
yes, sir. The bilirubin is increased, HTPT also increased, alkaline phosphorus also increased. Prothrombin time is slightly increased, but INR is within normal as 1.28. Creatinine, albumin are within normal range. CA is in normal range, but CA19-9 is increased.
Yeah, Dr. Shivendra, I'm handing over him to you. You can ask
how you interpret these findings of CA19-9 5,900.
So it is a tumor marker. In case of carcinoma, any head of pancreas, the tumor marker will increase CA19-9. So it is increased more than 5 times, more than 5,000.
Is it diagnostic?
No, sir. It is usually, sir, more prognostic, and it is specific but not diagnostic.
Whether any role of bilirubin high of 18 milligram has an impact on CA19-9. Whether you can take it in consideration or it is of no value. Because his bilirubin is 18.
Yes, sir. Sorry, sir. I don't know the relation between bilirubin and
in presence of so much deep jaundice, there is no value of CA19-9 to assess for any prognosis or diagnostic value. Once the bilirubin should come down, and that level, the CA19-9 comes to be important.
Good. Thank you, Dr. Shivendra. Next, what do you want to do?
Sir, I want to do a CT scan of pancreatic protocol or contrast and CT scan of abdomen.
So before that, do you like to carry out any ultrasonogram, or there is no role of ultrasonogram in this patient?
Ultrasonography is, according to the NCCN guideline, ultrasonography is not recommended now, as it is a case of suspected case of carcinoma head of the pancreas, we can do the CT scan, contrast and the CT scan if facility available. CT scan of pancreatic protocol should be done.
But NCCN makes it because they are recommending based on CA head pancreas. You don't know whether it is CA head pancreas.
Exactly.
Okay, sir. Okay,
How
sir.
you come to know the CA head pancreas? It could be any other, and if you do ultrasound or is studied with liver mets.
Okay, sir. So
Basic investigations should be done first.
okay, sir.
Dr. Shivendra?
Yeah,
Okay.
I think in general practice, if this patient comes up, you always get ultrasound
Right.
most of the time just to see what is the side. It could be CAGB neck with a block at the hilum. So ultrasound will give a lot of idea how to investigate further.
Right. Thank you, Dr. Professor Marcus. Marcus, sir, will you make any comment about this investigation state where a student is telling the CT scan? Sir,
with these investigations, you can only go for ultrasonography to see the condition there.
Exactly.
But a CECT is better than ultrasonography, will be more informative than ultrasonography.
But a basic investigation ultrasonogram should be done fast. And that
no. Basic investigation ultrasonogram, why should we do it? Well, the hepatobiliary surgeons will say that yes, this is a basic investigation. But for general surgeons, we will just wait for that results of CA and SCA, then ultrasonography, and then we go for that.
Exactly. What Dr. Shivendra was
maybe just 1 or 2 days back, difference.
Yes. Okay.
You do ultrasonography, you get the report on the same day, and then you can ask for the
next investigation. Okay, thank you, sir.
My question to Rajiv is that what findings you want to look for in an ultrasonography report that will gonna be confirmed by the CT scan?
So usually ultrasonography will give us if there is a metastasis in the liver metastasis. Liver metastasis is well seen in the ultrasonography than CT scan.
What other findings you want to look for in this kind
other
of
findings
patient?
Information. I want to see the location of the size, location of the tumor, size of the tumor, any involvement with other structure, ascites of the present or not, any lymph node involvement.
This is a case of obstructive jaundice. Don't you want to see anything in the biliary tree?
Sir, I want to see
level
whether
of obstruction, whether there is
whether
stone
there
or not.
Stone or not. Yes, sir.
And gallbladder distension.
Present or not, sir.
Okay, thank you. This is your ultrasound report.
Liver in normal size. Biliary channels, CVD is 2.6 centimeter, and intrahepatic biliary channels are dilated. Gallbladder is normal in size. On pancreas, normal in size. MPG is prominent 4 millimeter. A soft tissue mass is noted in the region of the pancreatic head, measuring 2.7 into 2.3 centimeter. Spleen was normal. So the impression was mass in the pancreatic head with dilated CVD and intrahepatic biliary channels.
Yes. So this is the thing, though. These investigations narrow your spectrum of thinking, has narrowed down. Okay. Then what you want to do?
And I want to do a CT scan of whole abdomen.
Dr. Shivendra?
You want to do a CT scan, you initially described something else, whole abdomen with some specific protocol that you want to get?
Yes, sir. CT scan of pancreatic protocol, sir, if facility available.
Any role of CT chest?
Sir, it could be a chest, it could be a staging investigation, sir.
Do you find anything abnormal in ultrasound?
In this ultrasound, sir?
Yeah.
Sir, there is a soft tissue mass present in the pancreatic, sir.
Only thing is the current fit, if there is gallbladder is normal side, it should be distended if there are some blocks lower down.
Yes, sir.
Either ultrasound radiologists have reported not properly, but either it should be dilated or distended. And you have said also it is a globular lump was palpable.
It's palpable gallbladder, right? Exactly. Exactly. Thank you, Dr. Shivendra. Okay, then. We don't have a video film of this CT scan or I have got a few images of these. So it's be very difficult to see exactly or the staging of pancreas lesion. So, however, I can show you the reports. I don't have the video. So this is the report of the CT scan.
Liver is enlarged, 17.8 centimeter. Gallbladder normal in size, no calculus is seen. Biliary tree is CBD is 26 millimeter, and intrahepatic biliary channels are dilated left more than to right. Pancreas mild heterogeneous contrast and hence is lobulated. Hypodense mass about 3.1 into 2.7 centimeter is noted, involving head of the pancreas compressing distal CBD and MPD. MPD is dilated 4 millimeter. Fat plane between adjacent structure is maintained. Subcentric para-aortic lymph node are seen. Impression was suggestive of pancreatic mass at head region. TNM classification is T2 and 0 M0 and dilated intra-extrahepatic biliary channels and MPD.
Tanvi.
Yes, sir.
Hello, Tanvi.
Yes, sir.
In your CT scan, gallbladder is normal in size. We are seeing that gallbladder is distended.
At the same time, ultrasonogram reveals that gallbladder is normal in size, but
in CT scan, we are please reveal the CT scan again. We are seeing the gallbladder. Gallbladder is distended.
Yes, sir. Yes, sir.
Are you seeing?
Yes, sir. Gallbladder is distended.
So gallbladder not in normal size.
Yes, sir.
Okay, will you make it? Please don't put any mark on the screen. Please erase the mark. Will you make any comment, Dr. Mohsin? Professor Mohsin?
Yes, sir. Actually, CT scan reveals already pancreatic mass in the head region. TNM staging is good. Yes, there is dilated inter and extrahepatic biliary channels. So gallbladder also distended. Sir, along with the CT scan, in this figure, you should do the chest CT. It's better. CT scan of the chest also to see any secondaries at the same time.
Okay. Okay.
Lungs also.
Okay, thank you. Dr. Shivendra, will you make any comment?
Yeah, I think whoever has reported has not properly put it, whether gallbladder was normal. Second thing is, Tanvir, what is the interpretation of ISBRD left more than right? Is there any significance of this or it is normal?
Diabetic biliary left more than right.
Left-sided. I don't know, sir.
I think normally whenever biliary arteries are dilated, left appears to be more dilated because left has a more extrahepatic course, then it appears to be dilated more.
Okay, sir.
There's no other value significance to this.
Thank you, Dr. Shivendra.
Yes, sir.
Okay, now we can proceed, Dr. Shivendra.
So our protocol is to, this is a CT, if it is resectable, we'll do a CT chest. And as such, there is no, on CT scan, there is no signs of any resectability or borderline resectability. So there is no role of PET scan. We'll do a CT chest. And if it is resectable, then we'll plan for surgery. That will be our plan.
Exactly.
Sir, I have more queries because what the radiologists have reported we want to know more about the pancreatic lesion regarding its where it is located, and its relation to the portal vein, hepatic artery, and others.
It was not a pancreatic protocol, I think.
Only thing is, we are hoping that they have reported that fat plane between the adscent structure is maintained.
Exactly. Only informations.
I think all those should be findings should be reported.
Yes, sir.
Right. So ultimately, CT chest was done, but the report is not with me. But the CT chest was normal, and the patient had such. What sorts of surgery you plan for this patient, Dr. Tanvir?
So I want to, after doing the multidisciplinary team approach, I will prepare the patient for the surgery. And if first of all, I want to do a staging laparoscopy and then proceed. And if no peritoneal metastasis or asset is present, then we can go for the pancreatic duodenectomy, which will proceed.
How will you counsel your patient?
In case of first of all, this is a case of head of the pancreas. So it in CT scan there is no involvement of any type of in CT scan it is resectable, but during surgery, after doing the staging laparoscopy, there may be a chance of we cannot proceed for the surgery. And as the patient has a severe and preoperatively, in case preoperative counseling should be there. Yes, the patient has a serum bilirubin is 18, and we have to manage the coagulopathy. We have to give the patient serum injection vitamin K for 3 days, and to manage the coagulopathy after improvement of the nutritional status and dehydration. Yes,
I'm asking about the main important counseling point.
The important counseling point is the surgery can be done if all the things are available to our favor after doing the staging laparoscopy. And during surgery, after surgery, there could be a complication. Other things we have to counsel about the complication of the patient.
Professor Mohsin.
Sir, my question is to Tanvir that whether will you do the tissue confirmation before counseling?
No, sir. In case of so in case as it is a resectable tumor, the tissue diagnosis is not required because it could be a tissue diagnosis is not required, but it is not it is desirable but not mandatory. Sir.
Can you do the US guided FNSC from the pancreatic head mass? Yeah.
It could be done, sir. It could be done, sir. Endoscopy, ultrasonography guided FNA could be done in case of pancreatic head cancer, but it usually done in case of non-resectable tumor to confirm my diagnosis.
Yes. So my second question is, during counseling, if the party or attendants of the patient or the patient itself asking you, is it a carcinoma? How will you answer the question? Is it a cancer?
According to my history and examination and the investigation finding, it is more preferably it is a case of carcinoma. So I will counsel them that we will see it after the operation. During operation, it could be a life-threatening condition if we go for the tissue diagnosis before the operation.
I have a question for you.
Right. Another question.
Another impression is a feature suggestive of pancreatic head. How will you convince the patient that this is a case of pancreatic cancer? Number one, what is the difference between a CT pancreatic protocol and a regular CT? And is there any role of endosonography before going for any surgical intervention?
Sir, in case of CT scan pancreatic protocol, there are 4 phases, sir. Pre-contrast phase, early arterial phase, that is angiography, and pancreatic delayed arterial phase, and portal venous phase, sir. In case of normal CT, there is
in this report only it is said that there is a mild heterogeneous contrast enhancement. So it is very difficult. Number one. Number two, there is nothing mentioned regarding pancreatic cancer. They said that the pancreatic head mass. Okay.
Yes, sir.
So with this report, will you go for surgery?
As the patient has symptom, I want to go for the surgery, sir. Or if facility are available, I can do a CT scan of pancreatic protocol.
It could be something else. It could be lymphoma. It could be IgA associated cholangiopathy or pancreatitis. So I think endosonography should be preferred before going for surgery, or endosonography guided biopsy or FNA to confirm the diagnosis, because this report is not suggestive of malignancy.
Oh, yeah. Dr. Shivendra, what is practicing in your center?
As such, in general accommodation, I will slightly differ with Hashim. If there is a clear-cut hypodense lesion is seen in the pancreatic parenchymal phase, and there is a dilatation of biliary radicals as well as pancreatic duct, that is a double duct sign is present, then there is no need for doing any biopsy. Because even if a biopsy turns out to be negative, you can't leave it. You have to resect it. Because 90% time it will be malignancy. Only 8 to 10% might be other diagnosis. So even if it is negative, the treatment doesn't change. So if there is double duct sign and hypodense lesion on pancreatic protocol, parenchymal phase CT, there is no need for doing any biopsy.
Okay, sir. I'm asking this question for the examination purpose. We most of the case follow the Covacious law and double duct sign for making a decision regarding the surgical intervention, but for the examination purpose to highlight the value of endosonography, is it important to mention endosonography in this part of the examination?
Workup is not mandatory to do EUS in all patients, but if it is, you have to get a tissue diagnosis, then the EUS is required. Or if there is then doubtful or resectability, if on CT or you are not able to make it and there is some suspicion of involvement, then you can do endoscopic ultrasound. Otherwise, just for diagnostic purpose, at present is not recommended.
No, for the purpose of an examination setting.
Okay.
Exam setting also, I think for guidelines, nowhere it is mentioned that you do endoscopic ultrasound for pancreatic cancer.
Okay, then thank you, Dr. Shivendra. Dr. Rakib, do you think this patient bilirubin is 18 needs a biliary decompression before surgical intervention?
No, sir, because in case of if we do the ERCP, biliary decompression is indicated in some cases if there is a features of cholangitis or the patient has a increased jaundice with intense pruritus, diagnostic dilemma, or there is a chance of neoadjuvant therapy, or there's a delay between the surgery and the diagnosis and surgery. In this case, the patient has no history of cholangitis or pruritus.
Tanvir, his bilirubin was 18.
18, yes, sir.
Dr. Shivendra,
yeah.
If it is more than 15, it could be done, sir. But ERCP guided ERCP with stenting can increase the chance of infection after operation.
Dr. Shivendra, will you make comment?
Yeah, we usually don't do, but it is controversial because it's more than 15, and if the performance status is not good, though her bilirubin albumin level was normal, so I think her PS is good. So it is controversial, but many centers use 15 as a cutoff. We at our center use 20 as a cutoff, but that is almost in this borderline case. You can err on doing a stenting also, because 18 is the quite high bilirubin level.
Okay, thank you. So ultimately, this patient had a Whipple's procedures. Whipple's procedure, surgeon was done, I think, nicely performed, that surgeons. And ultimately the histopathology report came like this.
So histological type adenocarcinoma, histological grade 1, and lymphovascular invasion absent, perineural invasion not identified, necrosis absent, duodenum involved, and gallbladder and CVD was free from tumor. Near resection margin of duodenum free of tumor. Distal resection margin of duodenum free of tumor. Resection margin of bile duct free of tumor. Lymph node was 13, total 13 lymph nodes. No lymph node shows metastasis. So the pathological staging was PT3 and N0 and M0.
Okay then. So what you want to do now? Or what you will tell to your patient?
Sir, I want to form a multidisciplinary team approach and go for the consultant with the oncologist.
Oncologist.
Yes, sir.
Dr. Shivendra, what do you think? What will you make
Yes,
any?
What is missing in this report?
Mass is
What
missing.
should be the standard thing areas should be reported? How the pathology should be reported in CF pancreas?
Right.
So,
Dr. Baki, are you here? Have you joined?
Sir, Assalamu alaikum. Sir, আমি আছি।
Will you make any comment on this report?
Sir, I can see all the margin. Uncinate margin is not there. I think it has not been grossed. I'm not sure. And other things, I'm not sure.
I think for standard recommendation is either to follow a leads protocol. All the areas margin should be, and then it is cut like a slice. So, and then you have to report whether the anterior margin is free, posterior margin is free, the uncinate margin is clear, or the portal vein groove is there, that is free or not. All those margins should be reported. Unless it is not done a proper histology, you will miss all those margins.
Yeah, true. Agreed,
sir,
sir.
I have a question, sir. After the operation, we have to mark all the margins, sir.
It is marked by the pathologist at the time of grossing. He has to mark it.
Okay, sir.
Okay. Okay then. Dr. Kamal, are you here? You have joined?
Yes,
Hi, Masud, please.
ক্যান্সার আর পেরিএম্পুলারি ক্যান্সার আমাদের মিনিমাম
front right
যাবেন এখন
Minimum 6.
নাম্বার অফ লিম্ফ নোড আচ্ছা আমরা বাইরে সেখান থেকে বাইরে স্যার হাউ মেনি লিম্ফ নোডস
Is mute. How many lymph nodes be harvested in periampulary carcinoma? Shivendra?
I think the numbers are adequate. As such, the guidelines, 13 lymph nodes are okay.
So
Guidelines of 6
is the minimum number.
6 is the minimum.
minimum is criteria, but for staging, at least 6 lymph nodes should be there.
Yes.
But ideally, what we targeted at least should be more than 15 lymph nodes are there for this. But the guidelines, even 6 is okay.
Yeah, sir, there is one doubt also. At this extent of surgery, I don't think there is only 13 lymph node.
That all depends how aggressively your pathologist looks.
We have searched. Yes, sir. Yes.
That is very important.
Yeah.
Dr. Kamal.
Yes.
It is your duty now. What do you want to do now?
So I just joined very recently. I understand that it was a periampulary carcinoma.
No, carcinoma head of the pancreas.
Head of the pancreas, okay. Head of the, because you are discussing head of the periampulary. So in head of the pancreas, so first of all, hi to Dr. Shivendra.
Yeah, hi.
So thanks for joining. I see now Dr. Shivendra is more connected to Chittagong than Dhaka. I'm so happy to see that. So normally in this situation, what I as Dr. Shivendra was telling, that we are very happy that the margins are very clear, we will go around only with the adjuvant chemotherapy. But if we have any doubt about the resection, we will go for not chemo also, but chemo plus chemoradiotherapy. That is what I should recommend. I don't know what in RGCI you are doing, Shivendra.
Okay. Please make comment, Shivendra.
Hello.
Shivendra, can you hear me?
Yeah.
Yeah.
So
At
I will
RGCI,
be going for chemo, that I was telling.
only chemo. Only chemo we are give.
Yeah, but if
Only
there
if
is margin positivity,
margin
R1,
positivity,
then
R1
we will go
resection,
for
then
chemo.
a CTRT.
Exactly, and that was I was telling. With this, I will go
Yeah.
for chemo. But if I was having any nodes or having any margin positivity, then I would have gone for CTRT also.
Okay, then thank you. Thank you very much. আমার মনে হয় আমরা এখানে কেসটাকে কনক্লুড করি। আমরা একটু now we are going to the presentation of the Dr. Shivendra on the same topics. So I think after
one question.
To presenting the Shivendra, we'll take all the questions and we'll discuss. Okay, just write it down. Then we'll ask the question Shivendra directly. So I stop sharing. Dr. Shivendra, you please share your screen and please present.
Yeah. Good evening, everybody.
It's clear.
It's clear?
Yeah.
So, as you know, the CA pancreas is the fourth most common fatal cancer with a life expectancy of around 5% at 5 years. And the prognosis has not much improved in the last 20 years. The most patient presents in either metastatic or locally advanced disease. And the surgery is the definitive treatment with a 5-year survival rate of after resection of around 20%. But it is only possible in around 15 to 20% of patients. So just a brief about the anatomy, what area we decide. You see, this is the portal vein. Any tissue lying on the anterior to the portal vein is the neck of the pancreas. On the right side of this, it is the head of pancreas. Between this portal vein and the left border of aorta, this is body of pancreas. And distal to this is the tail of pancreas. This is important once you are planning for resection and location of the tumor. These things you should always remember this. So I think the clinical features, we have the jaundice, pruritus, epigastric pain, pancreatitis, gastric outlet obstruction. These are common features associated with anorexia, fatigue, weight loss, hepatomegaly. Always look for the supraclavicular lymph node, ascites, or deposit in pouch of Douglas. So most important investigation for assessing resectability is CT scan to if you're diagnosing of CA pancreas. And always is important to assess resectability as well as categorize the patient whether they are resectable, borderline resectable, or a locally advanced or a metastatic disease. So how it should be done. So MDCT protocol is important. It should be done preferably with more than 64 slice CT. Less than 3 mm section should be done, preferably 0.5 to 1 mm section. Never use a positive oral contrast, use a negative oral contrast. And IV contrast is used at 3 to 5 ml per second. And take arterial phase at 25 to 30 seconds. Parenchymal phase is important. That you should take at 45 to 50 seconds. And portal venous phase at 60 to 70 seconds. Always assess for the vascular involvement, especially for portal vein, SMV, common hepatic artery, celiac, and superior mesenteric artery. Always note whether the degree of contact is less than 80 or more than 80, whether there is a focal narrowing, contour irregularity, thrombosis, or polytrus. Always look for aberrant arterial anatomy because it is seen around 50% of patients. Always look for arterial anatomy and ask the radiologist to do a 3D reconstruction of the vessels if you are dealing with, especially with borderline resectable or a locally advanced pancreatic cancer. If you are planning a vein resection, always look for the anatomy of first jejunal vein, left gastric vein, and inferior mesenteric vein if you are planning a vein resection. Always structural reporting is important because that makes sure that everything is commented upon, and it is preferred that you do a structural reporting. Always, if you are evaluating as arterial evaluation, always look whether the contact is less than 180 or more than 180. Whether the tumor is extending to the first SMA branch. If it is first SMA branch is involved, high chances that it might be unresectable. Always look for the variant anatomy. This is important because that will make your life difficult easier if you know what is the variation in the arterial anatomy. This is the case. You can see this is the aberrant right hepatic artery arising from SMA. If you know beforehand, then you will not injure it or you will be able to save it. Otherwise, it used to be initially one of the contraindications for doing a Whipple's resection. But if you know most of the time you will be able to do a resection with aberrant right hepatic artery also. This is another patient. You can see this is right hepatic artery arising from the celiac directly, not from the common trunk with the common hepatic artery. So all these things once should you know, then it will be easier to do a resection. This is another patient. You can see this is common hepatic trunk arising directly from the aorta, not from the celiac trunk. So all these anomalies one should be aware once you are planning a Whipple's procedure. This again, you can see this is a large mass with the involvement of SMA. So those things, arterial involvement, one should be able to assess on a CT scan. Similarly for vein, always look for whether 180 degree, more than 180 degree, whether collaterals are present or not, whether thrombus is there within the vein, and what is the extent of thrombus. All this should be reported in the structural format. Then only you will not miss. So this is the various classification have been given, but I think a knockout radiographic classification is much easier and one should use easily. This is normal if there is no narrowing. If there is unilateral narrowing, it is type B. If bilateral narrowing is there, then it is type C. And complete obstruction with collaterals, then it is a type D. If you see what is the correlation with the histological involvement, you can see for type A, usually it is always accurate. Most of the time it is not involved. For type B tumors, it is around 50%. You will find if there is unilateral narrowing, there will be a pathological involvement of the portal vein. If it is type C narrowing, then most of the time 75%, there will be pathological involvement of vein. But if it is complete obstruction, then almost more than 90% will have a pathological involvement. So this, you can see this is a scan. You can see this is a hypodense lesion in the head and uncinate process. This is SMV, this is SMA. And there is clear-cut plane you can see. So this is a resectable pancreatic cancer. Then again, you can see this is type B. There is unilateral almost less than 180 degree. There is some loss of plane with the SMV, but SMA is okay. So this is type B involvement. Here you can see it is more than 180 degree or narrowing. This is type C involvement. And this here you can see the complete block. There's a lot of collaterals. This is type D involvement of SMV and portal vein. Always you see the arterial involvement. Once do a sagittal reconstruction, you can see this is a celiac trunk and hepatic. This is SMA. Here you can see this narrowed, and it's narrowed from the both sides. So it is most probably involved. Again, you can see this is a tumor which is in contact with SMA, but SMA is clearly free. There's no narrowing. So you might be able to resect this patient. So this is, I earlier showed, this is a clear-cut resectable. This is borderline where it is around 180 degree less than. If it is more than 180 degree or involvement of SMA, then it is locally advanced and high possibility of R2 resection is there. That is why these patients should be taken up with neoadjuvant chemotherapy or radiation before. So this is the various criteria have been done. This is the standard for ESMO, NCCN, ISGPS. This is a complex criteria. But important thing to note is, even in the venous involvement is less than 180 degree, this is taken as resectable. So this is important to note. The important thing to note is just to don't go into details, just to simplify it. If it is less than venous involvement, which is less than 180 degree, any vein, whether it is portal vein, SMV, then less than 180 degree involvement is resectable. If it is more than 180 degree venous involvement or arterial involvement less than 180 degree, it is borderline resectable. If it is arterial involvement more than 180 degree, then it is a locally advanced. This is just simplified to remember. And if you go in detail, most of the time you'll find same, except the unreconstructible portal vein is locally advanced. So locally advanced is arterial involvement more than 180 degree or unreconstructible portal vein or SMV. So important thing is less than 180 degrees venous involvement is resectable, more than 180 degree venous involvement or arterial involvement less than 180 degrees borderline resectable, arterial involvement more than 180 degree or unreconstructible portal vein is a locally advanced. So what is the staging workup? Usually CT thorax is sufficient. PET is usually not recommended by any of the guidelines, but it should be based on the center preference. And it should be done in all the patients with bulbar unresectable, locally advanced pancreatic cancer, mass more than 4 centimeter, very high CA19-9, and CA body of pancreas. All these patients should be done a PET scan because these patients have high chances of finding a peritoneal disease or metastatic disease. So in this group of patients, PET should be done. So come to the controversial topic with endoscopic ultrasound. It is not routine, but it is complementary to CT scan. The assessment of vascular invasion is quite accurate, but most of the time surgeons prefer cellular CT reconstruction to plan surgery or assess resectability. But EUS is important for pathological diagnosis. Never do a CT-guided biopsy. It is better to do a EUS-guided biopsy for pancreatic mass because of less potential for peritoneal seeding. What comes next? Whether a stenting should be done or a biopsy, or what is the role of tumor markers? As you know, the FNAC is not mandatory. Usually, if it is unresectable, then only a US FNAC is preferred. ERCP guided intracranial biopsy is only if you are planning a stenting, then one should do. Otherwise, US FNAC is much better. Usually prefer a covered short metal stent because it has a longer patency. You can easily replace it. So uncovered short metal is also not good. Covered short metal stent is preferred for longer patency. So CA19-9 is prognostic and not diagnostic, and usually it correlates with staging and resectability, and also the response assessment is very good with CA19-9. And it should be done prior to surgery, usually following surgery prior to adjuvant therapy for active surveillance. So what is the role of preoperative biliary drainage? So it has been remained controversial. Usually just to take care of jaundice or pruritus is not required. And the recent study does not support routine preoperative biliary drainage. Indication remains if there is an active cholangitis, and when surgery is scheduled more than 2 weeks because of some logistic reason, or you are planning a neoadjuvant treatment, then the preoperative biliary drainage should be done, or a bilirubin level more than 20. This level is controversial. Many centers use 15, many centers use even 10, but usually we prefer at 20, but this as a center, one has to decide. Level is not very important. Coming to the staging protocol, you can see in none of the T staging, there is involvement of venous involvement is included. So venous involvement is not very important for T staging. More important is size and the involvement of artery, whether it's celiac, superior mesenteric, or common hepatic artery. These are important, but not the venous involvement. Also, number of nodes, if it is less than 1 to 3, it is N1. More than 3 is usually taken as N2 disease. So once you have evaluated, once you should categorize the patient, whether it is a resectable CA pancreas, borderline resectable pancreas, locally advanced or metastatic CA pancreas, and plan the management accordingly. If it is resectable and you are planning a pancreatic resection, staging laparoscopy should be done, but it should not be done in all patients. The guidelines recommendation is if it is more than 4 centimeter mass, if it is borderline resectable, locally advanced pancreatic cancer, body pancreas or left-sided, CA19 more than 250 if it is non-jaundice patient. Or if there is some indeterminate liver or peritoneal deposit on CT scan or PET, which you are not able to characterize. In this group of patients, staging laparoscopy is must, not in all patients. So once you do a staging laparoscopy after opening, then you assess resectability. Once you cauterize, it is better if you are send intra-aortic lymph node sampling for biopsy if you believe that these are going to change your treatment plan. This is again controversial, but many centers don't proceed if intra-aortic lymph node is positive. But the evidence shows that even if intra-aortic lymph node is positive, you can proceed with resection if you can do it with reasonable good long-term, reasonable morbidity and mortality. So high volume center can proceed with it even in intra-aortic lymph node positive disease. So because it has been shown that if you do a Whipple's, you have a better survival in these patients if you don't do Whipple's in these patients. Coming to surgery, if the CA head pancreas, the Whipple's is a standard procedure. If it is CA neck or body, then either you do plan a Whipple's with extended pancreatic resection or do a subtotal distal pancreatectomy, depending on what is the extent of involvement of the body of the tumor, body of pancreas. For CA tail, a distal pancreatectomy is sufficient. So I will stress on the few important technical issues in Whipple's. First comes the SMA first approach. What is the SMA first approach? In the standard Whipple's, we do SMA resection after transecting the pancreas, and we don't go dissect around the SMA. Usually we transect the pancreas and just remain lateral to the portal vein or SMV. But that is for standard Whipple's. You can do this for periampullary carcinoma. For CA head pancreas, one should do excise the whole of the mesopancreas and go to SMA. So this SMA first approach, you can do dissect the SMA so that upfront you know that the SMA is free. So one criteria of unresectable is gone. So it is better for CA pancreas to do SMA first approach, but it is not mandatory. Few of the things are indicated that when SMA first is definitely beneficial. I will come to those things again. For artery first approach, important is it gets early determination of resectability before committing on irreversible step. Reduction of intraoperative blood loss because you ligate the artery first, or IPDA, inferior pancreatic artery is ligated first, so there is no congestion in the pancreas. So also the complete dissection of the connective tissue from the SMA, so R0 resection rate is better. These are the usual aim of SMA first approach. And these are the various approach. The mesenteric or left posterior approach is mostly used by Japanese centers, and many centers use posterior approach or the anterior approach. The superior approach is more difficult to do from the top to do SMA. So this is the right posterior approach, very easy. You to cauterize, locate this aorta SMA and trace it distally till the duodenum. And you will find inferior pancreatic duodenal artery here, and you can ligate it upfront. And then dissect this whole of the SMA from behind. This is the SMA first approach. The mesenteric approach is you dissect at the root of mesentery below the transverse mesocolon, identify the portal vein as SMV and SMA, and ligate the inferior pancreatic artery from below, preserve the middle colic. Okay. So this is how you can do a mesenteric approach. But if it is very fatty patient, many times it is not easy. So what is easier is to do is either posterior approach, or this is another approach from the medial anterior approach. You can do the portal vein, this is retracted laterally, and identify the SMA and dissect it till the inferior body of pancreas, and lift this pancreas up and dissect it till the aorta. This is how it looks like. Portal vein and SMA is hooked up and dissected till the pancreas. The left posterior approach also comes handy. You mobilize the DJ flexure and trace from the SMA from behind. And here also it is very easily accessible. So combination of this left posterior approach as well as the right posterior approach, you can combine and join it. It is easier to do combination of right posterior and the left posterior approach. So, but if you go in the data, there is a randomized trial which has shown there is no difference in either R0 resection rate, no difference in postoperative complications, or in these patients. But problem was in this patient, even a periampullary malignancies were included, so it doesn't apply to locally advanced or borderline resectable pancreatic cancer. So SMA first approach is preferred if you are suspecting SMA involvement. There is a replaced or accessory right hepatic artery. Then if you do dissect, then you identify the aberrant artery and you will preserve it. If it is a portal vein assembly resection you are planning, then it is better to do SMA first approach, so that at the last step you can do or resect the portal vein and do the reconstruction. And if there is involvement of neck of pancreas. So coming to the second controversial new concept, that is concept of mesopancreas. You can see this is the uncinate and this is the artery. Once you retract the portal anatomy, you locate the artery, and there will be tissue of fiber fatty tissue and with nervous tissue which lies along this uncinate and the SMA. And this is the mesopancreas. Once you are doing a surgery for celiac pancreas, all this tissue till the SMA should be resected because this is the most commonest site of getting a R1 resection. And this is called uncinate or retropancreatic margin. So this you can do. This is the systematic pancreatic resection, 3 types, which is LV1, LV2, and LV3. The LV1 is standard. You can use it for all periampullary carcinoma. Just remain lateral to the pancreas, and you can need not to go to the whole exercise, the mesopancreas, till the SMA. This you can do for periampullary carcinomas, not for celiac pancreas. For celiac pancreas, if resectable, you can do a LV2 resection. You can dissect till the SMA, but clear the 180 degree. But you need not to do the adventitial resection. But if it is a locally advanced cancer, then you have to do LV3 resection, mesopancreas resection, doing the subadventitial resection from the SMA. So this is the LV1, V2, and LV3. So this I will do. This is LV1 dissection is for right side of SMA, and LV2 is coming to the left side from the right side of SMA. So it is for celiac pancreas, this is for periampullary, and this is for locally advanced pancreatic cancer. This is just to simplify. Coming to what should be the extended, whether do a standard lymph node dissection or extended lymph node dissection. So these are the standard lymph node dissection, which is your peripancreatic and the CHA and the superior mesenteric. You need not to do extensive para-aortic or aortocaval lymph node dissection. That is no benefit have been shown. There are a lot of randomized trial as well as meta-analysis, though have not shown that extended lymph node as associated with better survival or a better RJ resection, though it is associated with higher complication and the post-operative diarrhea. So the extended lymph node dissection is not recommended. So coming to the concept whether to do upfront surgery or neoadjuvant treatment, for resectable pancreas, the standard treatment at present is upfront surgery, but lot of data is coming for role of neoadjuvant chemotherapy in resectable pancreas. But for PG students, I think for resectable, you take it as surgery is best modality, and for borderline resectable and locally advanced, role of neoadjuvant chemotherapy comes. So for borderline resectable and locally advanced, the neoadjuvant treatment should be offered. What is the basis of neoadjuvant treatment? It helps in downsizing the tumor. It also gives the time to assess the biology of the tumor. Also, giving chemotherapy will treat the occult or micromets. It also achieve a better R0 resection or decrease the R1 resection by stabilizing the margins, especially if you use a radiation. Also, if you do a neoadjuvant treatment, at least upfront surgery, around 50% patients are not able to receive adjuvant treatment because of the complications of pancreatic resection. So they miss any systemic treatment. So the chances of failure of these 50% of patients is high. And this is the main basis of giving a neoadjuvant treatment, especially in borderline resectable and locally advanced. So you can see even if you do R0 resection, many times on microscopy, it will come out to be positive because there is a tendency of pancreatic cancer to spread around the nerves, and the perineural spread is very common. So even in the best centers, the R0 resection rate, R1 resection rate is around 30 to 40%. This is, you can see, these are R1 resection of John Hopkins, Dr. Buchler centers, and the most of the common aspect of PRODIS trial. If you do a good systemic assessment by protocol of Leeds protocol or a CAP protocol for celiac pancreas pathology assessment, the R1 resection is around 30%. So even in best centers, you are achieving R1 resection. So you can't predict whether it will be R0 or R1 before surgery. That is the basis, one of the basis of given neoadjuvant chemotherapy. And also if you use a preoperative chemo radiation, the R1 resection rate decreases. So the local failure rate also decreases. That is also one evidence basis for giving or neoadjuvant chemotherapy or radiation, especially in borderline pancreatic cancer. Also, it has been shown that one person fears if you give neoadjuvant chemotherapy, few patients will not respond and the patient will miss the chance of surgery. But if you analyze all the patient trials, the chances of progressing the patients locally is very less. Most of the time you see that they are resectable. Most of the time these patients fail on neoadjuvant chemotherapy systemically. This you can see, this around 20% patient will fail on neoadjuvant chemotherapy because of progression to mets. What does this show? This shows that there is these patients were harboring occult mets which has progressed even after neoadjuvant chemotherapy. So even if you have done resection, these patients were going to fail very early with sites at a liver, peritoneum, or elsewhere. So that is why the neoadjuvant chemotherapy gives a chance to treat these occult mets. And also, if you do a neoadjuvant chemotherapy and there is pathological good response, the survival improves. The patient who achieve a good pathological response have a much better survival patient as compared to less response. And that is why the concept of neoadjuvant chemotherapy and the important landmark trial was PREOPANC trial, and which included both the resectable as well as borderline resectable pancreatic cancer. And they have shown that with the neoadjuvant chemotherapy, there was a better disease-free survival, lower lymph node positivity, and perineal invasion, especially with chemoradiation. If you look for the borderline resectable pancreas, this trial showed that OS, disease-free survival, and R0 resection both increased with neoadjuvant treatment, and R0 rate you can achieve up to 79% as compared to immediate surgery, which was around 30%, 13% only. So this is the meta-analysis. This also shown that neoadjuvant chemotherapy improves overall survival and in borderline resectable pancreatic cancer. And that is why the NCCN as well as ESMO recommends neoadjuvant chemotherapy for borderline resectable pancreatic cancer. Especially FOLFIRINOX is the preferred regimen. Second option remains a gemcitabine with nab-paclitaxel. So how, if you give neoadjuvant chemotherapy, how you will assess the neoadjuvant treatment, how to evaluate? So first is when to evaluate, if the radiotherapy has been used, you do reassessment after 6 weeks from the completion of radiotherapy. If only chemotherapy was given, reassess after 2 weeks from the last cycle of chemotherapy. How to evaluate? Usually CT is chest and abdomen is sufficient, and if you require, you can do a PET CT also. The most important is one should assess the clinical response. There is improvement in pain, weight gain, general well-being. CA19 should decrease or at least remain stable. Always on CT scan, important thing is to rule out the progressive disease. Even if it remains stable, it is taken as a good response. If the borderline resectable pancreatic cancer, one should assess whether vein is reconstructible or not. If it is reconstructible, then you can go ahead and do so. In locally advanced pancreatic cancer, always CA19 is important. It should decrease by more than 15%. Then only one should take up for these patients for surgery. So reassessment, PET is always to rule out development of distant mets. On CT, it is not accurate to assess resectability. Even on the response assessment, if the patient has not progressed, one should explore these patients for assess resectability if the portal vein or assembly is reconstructible. Always look for the halo and string sign. I will come in detail what are these signs. And proceed even if there is a stable disease. Always do staging lab in these patients before doing a laparoscopy. So coming to the special aspect of venous resection, and if there is vein involvement, role of arterial divestment or arterial resection in these patients. I will come in detail about what is divestment. And always in these patients, do extensive cauterization, do extensive cattle brass, and SMA first approach is better in borderline resectable pancreatic cancer and locally advanced pancreatic cancer. So portal vein resection could be wedge resection. If there are wedge resection, it is type 1 if there is suspicion of narrowing. then one can use a portal venous patch. You can use a peritoneum, bovine pericardial patch, or use like this venous reconstruction. If there is more than 30% segments is involved, then a segmental graft is required. So usually up to 4 centimeter you can resect without graft. If it is more than 4 centimeter, then you can use autologous vein graft, either IJV, left renal vein, or external iliac vein you can use. Or if you have a transplant center, you will have graft vein graft. And if it is not available, you can use a PTFE or Dacron graft. And last, if it is not available as a peritoneum, you can use, make it a tube and do a reconstruction. Always, once you are doing a segmental resection, one should see whether the splenic vein needs to be ligated or reimplanted. Most of the time, if you ligate, the chances of developing a left-sided portal hypertension is there around 30%. So if it is better to reimplant if there is a portal vein SMV junction is involved. Always, if you do a CT scan, if the portal vein involvement is till the inferior border of duodenum, then most of the time you will not be able to reconstruct because the vessels will be going inside the root of mesentery. So always it is once you do a coronal reconstruction and the arterial, whether it's artery or vein, if it is the involvement is below the inferior border of duodenum, these patients you will not be able to reconstruct. These things are important once you are planning a resection. So graft, what you can do is autologous vein is better as compared to all because the thrombosis rate is better. And otherwise, if there is no availability, you can use a parietal peritoneum or a synthetic graft, PTFE or Dacron graft you can use. You can see for type 1 reconstruction, this is the Buchler Center's experience of 694. You can see there's still the type 3 reconstruction, that is segmental resection, accounts for 70%. And second commonest is wedge resection. So if you see whether wedge is inferior to segmental resection, lot of data, if you can achieve a negative margin, so wedge resection is not inferior. If you can do resection without compromising on the lumen and RJ resection, the tangential or the segment resection is equally as compared to segmental resection. So coming to this is the meta-analysis of portal and assembly resection in pancreatic cancer. You can see with the resection, you can achieve a median survival of 19 months versus 14 months if you don't do a resection. So because with or without venous resection, the recent data shows you can achieve a median survival of 25 to 29 months versus 18 months if you don't resect. So this is one of our patients. You can see this is the only a sleeve is involved. You can do a simple partial or tangential resection. Here a sleeve of the portal vein was resected. This is another patient. This large segment is involved. Chances of narrowing is there. You can see that we have ligated the left. This is the splenic vein. This is left gastric vein, and this is the superior. All these things should be controlled. Even the IMDs should be taken control if you are planning a segmental resection. And this patient, we did a segmental resection. You can see this is a portal vein, this is SMV, and this is splenic vein. So this is just at the level of junction. We have to do a response. Coming to the management of arterial involvement, there are two options. One is divestment and other is resection. What is divestment? This is a periinfilled adventitial resection to separate artery from the mass. If you see the arteries cross-section, there is a tunic beyond the tunica media. There is usually external elastic lamina is there. If you do dissection in this plane, this is subadventitial dissection, or beneath the tunica externa or beneath the adventitia. And if this adventitia is clear of tumor-free, you can do a subadventitial dissection and avoid resection. So this is how it is used, and it should be done only after neoadjuvant treatment, because then only you can sterilize these margins. how to select a good pancreatic protocol is must. And in this, you have to look for the halo sign. If the halo sign is present, you can be able to do a divestment. If there is string sign, then you will not be able to divestment. You have to do a resection. So what is this halo sign? In this, you can see this is SMA, which is surrounded by the neural involvement. It is SMA is involved. But see in the sagittal section, there is no narrowing. The tissue is there around this, and this could be sterilized could have been sterilized only a fibrotic tissue. There might be no cancer cell in this tissue. So there is this, you can see there is no narrowing. So this is a halo sign. You find there is a tissue around the SMA, but there is no narrowing. So in these patients, you will be able to do a divestment and do the resection. Do a resection without need to do arterial resection. In this patient, again, you can see this is all hypodense area around tissue around the SMA. But in this, you can see this area, there is some narrowing of SMA. So this is a string sign. You will not be able to resect this tumor without doing the arterial resection. And these patients should be either abandoned or one should plan for arterial resection. So the important thing is once you explore, do a subendometrial dissection, send the tissue for frozen. If it is clear, do a divestment and proceed. If it is positive, then either you have to abandon or do arterial resection. So this is the triangle operation. Once you are locally advanced, these all vessels, this is CHA, this is portal vein, and this is SMA. And this all triangle that forms, all this tissue should be cleared for all surgeries for locally advanced pancreatic cancer. So coming to arterial resection, if you're planning arterial resection, one can do end-to-end anastomosis, use anastomosis with adjacent vessel, either splenic vessel or gastroduodenal artery you can use, or you use a saphenous graft or cryopreserved arterial graft or PTFE graft you can use. This is one of our patients with aberrant, this is aberrant right artery, which was involved in the head pancreas. So we used a GDA. This is the GDA stump. We kept the GDA stump longer and did a reconstruction. You can see this is the reconstruction, and this is the artery with good pulsation after the arterial resection. This is another patient of a CA body pancreas. With this, you can see that initially the CHA was involved, his splenic vein was involved, and just at the origin of celiac trunk, this was involved. The patient received neoadjuvant chemo as well as radiation, and this is post-radiation picture. So after this, we took her for surgery. This is after post-8 cycle for loss. You can see that this is our area is clear. Then we had did ramps with celiac axis resection and portal vein resection with reconstruction. This is portal vein resection and reconstruction. For CHA, we reconstructed with using saphenous graft directly from the aorta. So the divestment disadvantages, there might be slightly higher R1 rates because the frozen section are not always accurate. So R1 resection rate is slightly higher as compared to resection. And also the risk of pseudoaneurysm with divestment in long term is high. But the morbidity of divestment less than arterial resection, risk of thrombosis, erosion because of anastomosis is less. This another patient, you can see this is here, you can see this is tumor, but there is not much narrowing. Slight irregularity, but is not narrowing. This patient, we did a divestment there. Here also you can see this is tumor around the SMA. And this is the divestment. We could dissect it out from SMA completely. And this is what divestment we could do without doing a resection. So complete you can do arterial resection with good reasonable mortality of around 5%, morbidity of 41%, but the median survival is of 5 years old is only 13%. So at present, general consensus is arterial resection is not much beneficial, though the data is emerging, but at present, divestment is better option. And venous resection you can easily do with better long-term overall as well as disease-free survival. So coming to what approach should be there for locally advanced cancer, we use a neoadjuvant chemotherapy. If it remains stable, do explore send the frozen section from the artery, whether SMA or celiac. If there's no vital tumor or frozen section is free, through a triangular operation with divestment. If the tumor is involved, to take up the patient for palliative chemotherapy. So, for coming to distal pancreatic resection, important thing to note is this is the body of pancreas, this is the neck, and this is the tail. So the concept of ramps have come for distal pancreatic resection. This is radical antegrade modular pancreatosplenectomy. This is important because this achieves a better circumferential margin because it takes care of the posterior margin. And this was first described by Strasberg. And it achieves better posterior extent of resection, better nodal clearance. And that is why two types of ramps are described. If you do not resecting the adrenal, and the plane is anterior to adrenal, that is anterior ramps. Or if you are excising the adrenal gland, then it becomes a posterior ramps. And you have to go till the renal vein, take all the tissue anterior to the renal vein, excise with the gyrotas fascia, that is ramps. And you don't mobilize the tail of the pancreas before, transect it, and do a medial to lateral dissection so that plane is well preserved and under vision. So this is one of patient. You can see this is body tumor, and this we did a ramps. This is one of the mobilization. After this, you can see this is the CHA and this is SMA. This is renal vein. The complete area should be built. All these tissues should go ahead. All the gyrotas have been involved. This is SMA. This is common hepatic artery. All these tissues should be cleared for ramps. This is the same patient, and this is the specimen. Coming to the Appleby procedure, Appleby was originally described for gastric carcinoma for giving a good lymph node clearance around celiac axis, and Neura was the first person to use for CA pancreas. It is actually the excision of the celiac axis, including the CHA, celiac, and the splenic artery. Important caveat is one should be able to preserve the gastroduodenal arcade, or there is good collateral development from that. So coming to this, in this again, all tissue needs to be excised. This is ramps the same, except that you have to excise the celiac as well as CHA, preserving the gastroduodenal artery. For that, it is better to use a preoperative angiography to assess whether the gastroduodenal arcade is maintained or not. This angiography, you can see the gastroduodenal arcade is maintained, then you can resect it. Many times people have used embolization just prior to that, gastroduodenal artery, so that this channel opens up more before doing an Appleby procedure. Coming to the status of total pancreatectomy in pancreatic cancer, usually it is required if it is multifocal pancreatic cancer, which is around 9% only, or extended lymph node or more lymph node rejection, especially if there is a tail is involved. And in this patient with IPMN, where the multifocality is there, atrophic, the remaining pancreas is very small, and multiple mets, especially if the renal carcinoma, if you're doing a resection for renal carcinoma, mets in the pancreas or endothelial pancreas or familial carcinoma, these patients, total pancreatectomy might be required. So with the advancement in the post-operative sugar management, you can use better insulin formulations. You can use auto islet cell transplantation. We don't do it. We usually better with insulin, you can easily manage with present. And with the availability of pumps, it is easier to manage even after total pancreatectomy. This is a patient of IPMN. This you can see the hugely dilated pancreatic duct. This is a whole pancreas was involved, and in this we did a total pancreatectomy. You can see this is a specimen. This is all vessels are clear, and this is the total pancreatectomy. Both remain very rare indication, but once in a while you need to do a total pancreatectomy. To summarize, once you do a resection, resectable pancreatic cancer, do directly for surgery. What our protocol is, even if resectable but portal vein involvement, even if it's less than 180 degree, we prefer giving neoadjuvant chemotherapy followed by the surgery if the patient remains a stable disease or partial response. In borderline resectable pancreatic cancer, we usually give 4 cycles of FOLFIRINOX Even if remains stable, we give radiation and then take up for surgery. For locally advanced pancreatic cancer, we usually prefer 8 cycles of chemotherapy. If it remains stable, give radiation, then take up for surgery. So to conclude, CECT with pancreatic protocol is must for proper categorization of resectable pancreatic cancer and borderline resectable pancreas. Neoadjuvant chemo should be preferred over upfront surgery for BRPC and LAPC. For neoadjuvant chemotherapy followed by RT and then surgery is better for locally advanced pancreatic cancer. Portal vein SMV resection can be done with reasonable morbidity and mortality with good disease-free survival. But arterial resection can be avoided by divestment in many cases, but if required, arterial resection can be done in well-selected patients. Thank you.
Yeah, thank you very much, Dr. Shivendra, for your brilliant presentation and a masterpiece presentation, I should say. Well,
I think I've not gone into details of surgical steps of Whipples or the complications of Whipples. If there are questions, then I can discuss on those points.
Yeah, sure. Sure. Dr.
I'll stop sharing this.
Yes, now we'll take the questions from the students. Dr. Asan, any question in the chat box? Can I quit sharing your here?
Yeah, definitely.
Okay then. Yes. Dr. Asan, are you here? For Saiful, any question from the chat box or here?
Sir, so far there are 2 questions only. How to differentiate between head of pancreas and cholangio by history and clinical examination? I think this this question is discussed already.
Okay.
Any role of MRCP in head of pancreas?
Dr. Shivendra.
At present for MR is very rarely for head pancreas, especially unless you have a body tumor or multifocality is suspected. Sometimes for IPMN or a cystic tumors, MRI is required. For clear-cut head pancreas, not much benefit of doing MR. You can get all the information for MR, but CT is preferred modality for head pancreas.
Sir, the problem is that here in this part of our country, sir, sometimes we practically face these problems every day almost. So patient initially comes with obstructive jaundice. We do a ultrasonogram and it is reported choledocholithiasis. We do CA19-9. It is 1,000 or 2,000 or 3,000, whatever it is. Then we tell the patient to do MRCP. So MRCP also reported there is a stricture at the distal end of CVT, multiple stone in the common bile duct. And ultimately, this ends up by doing laparotomy, multiple nodes, pancreatic nodule, either this is head of pancreas or distal cholangio. So
I think if you're finding a stricture, it should be evaluated by endoscopic ultrasound or ERCP, taking a brushing from that stricture area. One should be evaluated for the stricture first.
Sir, problem is here, sir. We don't have EUS in our country at all.
Then if the stricture is there, the other option remains doing a ERCP, taking a brushing. Though the yield of brushing is less, but that is the other option for doing for assessing the local lower end strictures.
Okay, sir. Sir, next question was how many lymph nodes need to be positive for radiotherapy?
So at present, what our criteria is lymph node positivity is not an indicator for giving radiation.
Yes.
Because if the bulky nodes are there and the lymph nodal positivity is more, the chances of patient failing systemically is more high as compared to local failure. Important is R1 resection, always you need to give radiation.
Okay. So, and the last question was from Soyed Mohammad Jamal Parvez Choudhury. He asked about how anastomotic leakage is detected post-operatively. So, which anastomosis he's talking about, I don't know.
I think it must be talking about the pancreatic leak.
Yeah.
So always the standard definition. There is no standard definition for ISGPS classification for pancreatic leak. One should do always, at least for day 3, one should do amylase, serum amylase as well as drain fluid amylase. If it is more than 3 times of serum amylase, it is pancreatic leak, and one should manage
Yes.
for this.
So, what is pancreatic protocol?
Pancreatic protocol, I think I have described in our
Yes, sir.
slide.
Yes, sir.
You
You have
have to
already
do
described it.
the parenchymal phase as well as 25 to 30 seconds the arterial phase. Around 40 seconds is the pancreatic parenchymal phase.
Yeah. Okay.
Can you ask any question directly? Any
Sir, I am Dr. Shantanu Bishwas.
Yeah.
I am now working in HPB in BSMMU. So first of all, I want to give thanks to Professor Khandekar Azad sir, and also want to give thanks to our guest lecturer, Professor Shivendra. I have some few questions.
Yeah, tell.
3 to 4 questions. Number 1 question is, when we are going to deal with the locally advanced pancreatic tumor based on the imaging findings like CT scan and CT suggesting this is locally advanced tumor. Now we are going for upfront chemotherapy. Before that, when we have done the US guided FNAC, or as it is not available in our country, so we usually do the transperitoneal FNAB or FNAC. So when it comes negative, so how can I deal this patient?
That is difficult because of your logistic reason. The facility is not available. You have to try but to get even a transperitoneal biopsy is okay. If it is not, you can't start neoadjuvant chemotherapy without the biopsy proof.
So how can I deal with this patient? So this is certain that this is a malignant lesion in CT scan. Obviously, this is in pancreatic protocol CT. All the characteristics of malignancy is there.
But the problem is, if you don't have the biopsy, then it is difficult to start chemotherapy. I think Professor Kamal will be better person to tell. Standard is get the biopsy. Without biopsy, you will not be able to start.
Yeah.
Once in a while. Yeah.
No meet, no treat. Tissue is the issue. No meet, no treat.
Yeah, definitely. Without biopsy, I think it is not possible.
Ethically, we cannot. Yeah. Only in liver, only the liver malignancy without biopsy we can check. But here, without tissue diagnosis, ethically we cannot go for any neoadjuvant.
So, as this is a locally advanced disease, so how can I proceed in the next step?
Because even with laparoscopy will not be able to take a biopsy. So other option remains upfront surgery. If your setup is like that, but locally advanced, you will not be able to resect. Most of the time, you will be ending doing a bypass.
Okay. So can I proceed to my next question?
Yeah.
Okay, I am giving you 2 scenarios. Number 1 is when I was dealing with the fresh pancreaticojejunostomy for a chronic pancreatitis, and I have sent the and there is no frozen section facilities. And after sending the histopathological biopsy, the histopathology report comes malignant after 7 days. And this is one scenario. Another scenario is I have done fresh pancreaticojejunostomy. Patient is well compliant with that surgery, and there was no pain postoperatively. But after 2 years or 3 years, patient have come with chronic pain, and when it was re-evaluated, and there was a malignant lesion in the remnant pancreatic tissue found in the CT scan. So with these 2 scenarios, how I am going to deal with?
In the first scenario, once your phase procedure, after phase procedure, your biopsy came positive later on, this can happen in around 8 to 10%. Usually frozen section is always standard. If facility is not there and it turns out to be negative, positive, then the option remains either going ahead and do a resection and do a total pancreatectomy. Phase you have opened up, completely, the chances of doing a remaining duct will be a very less option. Other option remains just give chemotherapy as well as radiation, because now you have breached the planes, all the planes the tumor has spilled, so the chemotherapy will remain the main treatment.
Okay,
And after 2 to 3 years, if comes with
Then also, if
malignancy,
it is resectable, you do a resection.
resection means total pancreatectomy.
Most of the time, it will be total pancreatectomy. It is not easy to do a distal pancreatectomy in this patient.
Okay, then.
Sir, thank you.
So, are কোনো question আছে any from students?
If you permit me, I can ask another question, sir.
Sure.
Okay. So there is a patient with periampullary growth, which comes low-grade dysplasia in ERCP biopsy, or high-grade dysplasia, and there was no jaundice, and patient has no history of anorexia, weight loss, and this is the scenario. So in this situation, how can I deal with this patient?
Your issue is there is ampullary lesion, but the biopsy is low-grade dysplasia. What is the finding on CT scan? Whether double duct sign is there, pancreatic duct, as well as bile duct is dilated?
Bile duct is not dilated. There is no double duct sign. Bilirubin is near normal, around 1.7. And these are the scenario. So in this
then
situation,
if it is low-grade dysplasia and only a biopsy has been done, if possible, you can do a endoscopic mucosal resection or ESD of that area. But that facility is not there, then you keep a follow-up and do a sideway endoscopy again after 3 months.
And if it is high grade, sir?
High grade or low grade is very difficult to differentiate because there is no other evidence. It is very difficult to proceed for resection doing a Whipple's based on dysplasia only, unless you have a corroborative evidence of radiological evidence of malignancy. Whether bile duct is dilated or biliary stricture is there, then you can proceed. If there is no biliary dilatation, no pancreatic dilatation, only for dysplasia, it is difficult to do a justified resection.
Okay, thank you, Dr.
Okay, sir. Thank you. Thank you, sir.
Any question from a student? Okay, then. Very good discussion and a very vibrant discussion and the participation, Dr. Shivendra. এখন we'll take comment from our faculties.
স্যার একটা কোশ্চেন, আমাদের পরীক্ষায় কিন্তু প্যানক্রিয়াস প্রোটোকল মানে থাকে না, সেই ক্ষেত্রে আমরা কি ওইটার উপর ডিসিশন নিব যেটা থাকবে, মানে নরমাল সিটি স্ক্যানের উপরেই কি আমরা ডিসাইড করব রিসেক্টেবিলিটি, নাকি আমি তার কাছে আবার চাইবো যে?
You can ask question to Dr. Shivendra definitely. Shivendra, you can ask question. Shivendra, but she is asking about in the exam settings, there is no pancreatic protocol CT film in the exam. So only the CT scan film is there. So how decision will be taken?
If the what is the local availability of the, because every center has some limitations. You have to go ahead with the local facilities which are available, and you have to use the best, with your best knowledge, to use that facility. If the CT is there, even if it is not pancreatic protocol, at least you'll be able to see gross involvement of the portal vein assembly. You might meet a smaller final details, but still the gross involvement you'll be able to find. You should be able to find whether the completely blockage of portal vein assembly is there or not, there is collaterals or not. Both more bigger picture you will be still able to get. It is not everywhere you will be able to get a pancreatic protocol. Okay. But I think if you speak to your radiologist, it is very easy. Only a pump is required. All the CT scans you can do it. Even a 2 slides or 8 slide CT is good enough to a pancreatic protocol.
Okay then, thank you. Thank you. Any question from students? No. Now a comment about this webinar and advice to students. Dr. Rabdi, please make comment.
Well, it's an excellent discussion, presentation by Shivendra sir. He's always brilliant with his presentation, and he has covered almost all aspects of pancreatic cancer management. So my question to Dr. Shivendra sir, that if the patient is having pancreatic cancer and we are saying that this is a resectable disease, but the patient is having cirrhosis and it is detected on table and there is no features of signs of and features of chronic liver disease and CTPA, what should we do? Should we proceed for Whipple's, or we should proceed and we should postpone and decide later?
You can proceed with even in chronic liver disease also. If it is child A, and less than 8, you can proceed. And there should be no portal hypertension or upper GI endoscopy, no varices. You can easily proceed. But you have to tell the patient, because the chance of decompensation and mortality will increase around 15 to 20% risk will be there. But we have done even as chronic liver disease also. We have done around 8 patients for chronic liver disease with cirrhosis also.
Okay.
But,
Thank you. Thank you.
Thank you, sir.
Dr. Baki, will you make any comment?
Yes, sir. Very wonderful, nice presentation. Sir presented in a very beautiful way. As a pathology resident, we always pray that a Whipple procedure won't come to my day because it is very difficult in the grossing. But sir photographs were so nice and so easy, and so easily he depicted the whole scenario. I was thinking that I could have been a surgeon. Thank you, sir. Thank you so much for your brilliant presentation.
Thank you.
Thank you. Thank you, Dr. Kamal.
So everybody is telling a brilliant presentation. I will say that after listening to this presentation, at least we should make some change in our practice. Say, when I'm asking for imaging, we should write all the points that he has mentioned in his slide. That what is the thickness, what are the criteria that we'll be looking for? Because, you know, we are spending a huge amount of money getting a CT scan done and not getting the adequate information. And then we are landing in a soup and creating a mess. So I think this is very important, what Dr. Shivendra was mentioning, that the quality radiology is very important. And selection, I think that he was showing that R0, R1 is not a big issue. Big issue is the proper decision. And even they can go for surgery, even 20 milligram of bilirubin. That was the 20 was the cutoff. That is quite amazing. You know, sometimes when it is more than 10, we are scared that shall we go for ERCP, stenting and all these things. So I think there was some very interesting information he was mentioning. And most important thing that he didn't say that it is written in the book. He told that they are practicing it. That is the most, the robust thing. That what people do, not what they do. So they have their data. Today, I'm sure for the limitation of time, he didn't show his data, but they have their own data. So our colleagues were listening to them, that Dr. Shivendra is not copying or pasting from a book or guideline. He is telling what they are practicing. So they are talking with huge confidence. So we should be focusing on that, that I have done 20 cases. I should tell my experience that I have done up to 12 or 15 bilirubin and I was successful. This is very important. We should not look what we don't have. We should say what we have. And especially neoadjuvant, decision of neoadjuvant, what Rabbi is practicing now. But many should be use that technique. I mean, it is a support. Before doing the surgery, neoadjuvant chemotherapy, sometimes your neoadjuvant chemotherapy is also sometimes radiotherapy, chemoradiotherapy is also helpful to make it resectable so the life of the surgeon becomes more easy. So I think that is, thanks for mentioning those specific points that can really make a change in the practice and create a good impact. Thanks a lot. I'm feeling good that we were connected at the beginning.
Okay, thank you. Thank you, Dr. Kamal. Professor Margushan, sir, please.
It's difficult to make any comment, really. He was so extensive, and the slides, that is the CCT and other things, the operative pictures, all images were so clear. I wish I could do it.
Yeah, thank you.
So that we can go in with all information at hand, whether the artery is involved, whether the vein is involved, whether the duct is involved or not, what is the actual size of the tumor, and where it is lying. You can detect everything if you have a good imaging and good diagnostic tools.
Exactly, sir.
Sonography. So I wish we will do it in soon, as far as possible, and then go with that.
Thank you,
Thank
sir.
you, Shivendra.
Thank you. Professor Mohsin.
Thank you, Dr. Shivendra sir. Actually, you have explained every corners of the pancreatic cancer in a very excellent way. Initially, I have a bit sleeping, but later on,